Okay, so in last lecture on Tuesday, we studied vitamin C and vitamin D. Okay, now vitamin E. We have two names given in our first aid, tocopherol and tocotrienol. Okay, but mostly you have to remember tocopherol because this is the common used name. Okay, and then I told you about three vitamins which were antioxidants. One of them was vitamin A, then vitamin C, which we started on Tuesday, and then vitamin E. Okay, so these are the three vitamins, A, C, and E, which again are antioxidants. Okay, but when I was teaching you vitamin C, I told you a function of vitamin C, that it helps in, you know, the process of oxidation that goes on. If you remember, I told you that there is an oxygen that is converted to a superoxide. Okay, that is converted to a superoxide by an enzyme, and then that superoxide is converted into another product, and the final product which we have is HOCl, that is hypochloric acid, and this HOCl is the main compound which kills the bacteria. So vitamin C was playing its role in those things. Okay, also it was converting ferrous to ferric. But here, when we talk about vitamin E, its antioxidant properties are again on these free radicals. Okay, this is a free radical. O negative 2, it is called superoxide. Okay, so this is a free radical. HOCl is also a free radical, so it also works on these free radicals. Okay, and it destroys the bacterias, okay, via them. But it also has another very important function, which is like protection of RBCs. Okay, so you have to remember vitamin E function with respect to RBC protection. Okay. So like this is your this is the important point. So you have to remember this point for your exam purpose, that it helps in the protection of RBCs. Okay. And there's nothing like any other function of it. So vitamin E, there are very few MCQs that have been asked on vitamin E in like previous years also, so it's not too much. So you just have to remember this one function, that is antioxidant property. Okay. Then we have this deficiency. Okay, when I talk about vitamin E deficiency, now this is a point which you need to remember. I told you when we started vitamins, and we heard many of the names like sideroblastic anemia, megaloblastic anemia, microcytic anemia, iron deficiency anemia. So definitely sideroblastic is also a type of hemolytic, but they are very fond of, your examiners are very fond of asking MCQs in the same way it is written in your book. So when they will write sideroblastic, so at that particular moment, your mind should directly go on vitamin B6. Definitely, they will give some other hints also. But in your first aid book, they have mentioned that the sideroblastic anemia is because of the deficiency of B6. Similarly, we have megaloblastic anemia. Okay, we have megaloblastic anemia, and we have seen deficiency of vitamin B9 and B12 associated with the megaloblastic anemia, right? Similarly, we have this iron deficiency anemia. Okay, and this iron deficiency anemia is again because of vitamin B9. Okay, and iron itself. Okay, why B9? Because B9 is folic acid, okay, which is being converted to tetrahydrofolate, And if you remember, like I've kind of told you all these things in pretty much detail. So you have to like go to the previous lecture on vitamin B9 where I've like explained you. So now in vitamin E, you have to remember this word from this book, hemolytic anemia. If you'll go like after finishing vitamins, or I'll like try to show you some of the MCQs from your exams, okay, which are totally from the book. Like they don't ask any MCQ away from your first aid. Even if there is any, it's like one or two. So focus on the wordings. So vitamin E, just remember hemolytic anemia. What is hemolysis? Hemolysis means breakdown of RBCs. Because the RBCs are broken down due to the free radicals present. Okay, so in that cases, the hemoglobin count drops, and that we call is hemolytic anemia. Okay, clear? Now we have another terminology which is called acanthocytosis. What is acanthocytosis? You know, the shape of RBCs is, this is an RBC, and let's say this is the shape of RBC. Okay, it's like rounded. Okay, and it is biconcave. Okay, so this is like I'm seeing it from the top. But if I see this RBC from the side, it will look like this. If I'll see this RBC from the side, it will look like this. Okay, so this is a biconcave shape. So RBC's natural shape is biconcave. There is a reason that RBCs are of this shape, because when they have to move past these blood vessels, okay, these arteries, and when these arteries like move forward, they become narrow, and artery become arteriole, okay, and then capillaries. So they have to move from these structures. Also, when this RBC shape is changed, like for say it is more rounded, like a sphere, okay, or its shape is like a sickle, like this, okay, or its shape is like a star, like this. So when the shape of RBC is changed and they go into the circulation and they reach the spleen, okay, so they have to pass that network of arteries present in the spleen, okay, but because of their shape is no more biconcave, and it is like a sickle or sphere or star shape, they got stuck there. And spleen is called the graveyard of RBCs. They are killed in there. So you have to be very careful with this concept, that if they're talking about this acanthocytosis along with hemolytic anemia, it means that we are having this hemolytic anemia, we are having this breakdown of RBCs because its shape is distorted. Okay, and the shape is acanthocytosis, like the shape of an acanthocyte. This is a word, acanthocyte, which means thorn. Okay, thorn. It has this RBC is spiked like this, somewhat like this. It's somewhat like this. So let me show you this shape. You see this? These are acanthocytes. This is acanthocyte. These are acanthocytes. So their shapes, they're like somewhat like star shaped. They have these thorns. These little things are called thorns. Okay, thorns. So this is acanthocytosis. So I'm just showing you this picture so that you may remember the shape of um, these RBCs. Okay. Now the next thing is muscle weakness, demyelination of posterior columns. Okay, if you remember, there was a very good picture in your first aid, but I have to go pretty much back to show you that, so it's better I may show you in here. Wait, if any one of you have taken my neurophysiology lecture that I have already recorded and uploaded for you in the drive, you people will understand it way better. Now see this picture. These are the posterior columns. Okay, this is the anterior horn of spinal cord. This is the posterior horn of spinal cord. Okay, and posterior horn is always dorsal, like we can call it posterior or dorsal, and it is always sensory. Okay, it is sensory. And anterior horn, or we can call it ventral horn, is always motor. Okay, so remember these things first things first regarding spinal cord. Now the area of white matter, now this butterfly shaped structure is all the gray matter, but these structures, this all structure, even these colored structures they have shown you, okay, they are all made up of white matter. Okay, and this region here is called your anterior commissure, and this region here is called your posterior commissure. So if you see these structures that are present posteriorly, they are called posterior columns. Okay, dorsal or posterior columns, it's also written over here. Now our today's lecture will be based on, our today's neurophysiology lecture will be based on this, so don't miss that lecture. Okay, because we left our previous lecture on this dorsothalamic tract, so we will be continuing that in detail today. So these are two nucleuses. Okay, one is called nucleus gracilis, or we call it fasciculus gracilis, and the other one is what we called nucleus cutaneus or fasciculus cutaneus. So this nucleus gracilis got the nerves from the lumbar and sacral plexus. Okay, and this nucleus cutaneus got the nerves from the thoracic and cervical plexuses. So these are for your, this is blue one is for your upper limb and yellow one is for your lower limb. Okay, so we will study in neurophysiology in detail, but the point which I want to enlighten here in biochemistry lecture is your vitamin E is responsible for the myelination of the neurons that are present at this particular level. Okay, I told you one thing in physiology class, that everything which is gray, even in your spinal cord or even in your brain, if it is of gray color or you call it gray matter, it means it is made up of cell bodies or soma. Okay, cell bodies or soma. And the white matter is called white because it has axons present. So this is a structure of a neuron. Okay, now this is your cell body, this is your axon, and these are your dendrites. So your white matter is made up of axons only, and your gray matter is made up of your cell body only. So this gray matter has all the cell bodies. Okay, and the axons to these cell bodies are present in your white matter. Okay, same goes here, like this. So these axons are basically neurons, right? They are the part of a neuron. This complete whole is a neuron. Okay, so on the axon we have a sheath of fat, a lipoprotein layer is present, which we call myelin sheath. Like this, on this neuron we have this myelin sheath. So that myelin sheath, for the synthesis of that myelin sheath, vitamin E is responsible. Okay, it is an important component of this myelin sheath. So when your body is deficient of this vitamin E, there is a process that occurs which we called demyelination. That means the myelin sheath is being destroyed, okay? Demyelination. So now if you understand the concept why I brought you to this picture, let's go back to your book, and you see what they have written: demyelination of posterior columns. So these columns, okay, these columns, when these columns demyelinate, what happens? These columns are responsible for certain functions like touch. You can even write it in your first aid, okay? They are you can write the name of these posterior dorsal columns, okay? They are called dorsothalamic tracts. Even you can make this picture in rough, okay? So it is responsible for touch. It is responsible for basically it is responsible for fine touch, okay? We have two types of touch: fine touch and coarse touch. So I'm writing F here, or I may write full. Fine touch, pressure, then vibration. Okay, I'm writing in short. And touch, fine touch, pressure, vibration, and position. Okay, so these nucleuses are responsible for your fine touch, pressure, vibration, position of your upper limb and lower limb, not your whole body. So make this concept also clear, because the yellow thing you see here was responsible for your lower limb. Okay, so we are not talking about the movements of lower limb here. We are talking about these functions: fine touch, pressure, vibration, and position. So someone give pressure to your lower limb on your skin, okay? Someone touch your skin of your leg, okay? The position of your this position of your thigh or your leg, okay? The vibration sensation that goes on in here. If you put your mobile phone on your lap and it vibrates, so you will feel that vibration, right? So all of these sensations that you are feeling goes has these nerves of lower and sacral plexuses, and those nerves take the signals from that part of your lower limb to this yellow nucleus, which is called nucleus gracilis, okay, present in the posterior column of spinal cord. And similarly, all these fine touch, pressure, vibration, and position that you feel in your upper limb are taken from the nerves of your brachial plexus, okay, brachial plexus. And brachial plexus is comprised of cervical and thoracic nerves, right? So those nerves bring the information to your spinal cord via this blue nucleus, which is called nucleus cutaneous, or we call it fasciculus cutaneous. So I'm just trying to make this good concept in your head, that what they have written in your first aid is they're trying to explain you that vitamin E, the deficiency, when vitamin E is deficient, its deficiency causes demyelination of posterior columns, okay, which will decrease the position and vibration sensation, okay? So when your myelin sheath is destroyed, when there is no myelin sheath present on your axon, the conduction becomes slow, because these myelin sheaths are responsible for the fast conduction. So I told you one rule: more myelination, fast conduction. The more myelinated the axon will be, the fast the conduction will be. Less myelinated, slow conduction. And no myelination means no conduction, or like very minimal conduction. So this is the rule. So now when they become demyelinated, D means no, like no myelination. So there will be no conduction. And if it will be like very, very slow. So that is why the patients that come to the come to your clinic will say that we are not feeling any sensation on our legs or any sensation on our arms. So your mind should, like, you can think of the neurological diseases, especially the disease of which is called SCID, which is severe combined immunodeficiency disorder. Okay, we have a problem with vitamin B12 in it and also vitamin E in it. So you see there is a spinocerebral tract also which is causing ataxia. So the patient will come into your clinic with these problems. So your mind should go for two vitamins. One is B12 and one is E. Okay. So just remember these points. So if you make a good concept, like you will not do your MCQs wrong. And when you will revise it like repeatedly from your textbook, from this book, you will learn everything in short time. Okay. So you don't need to mug the lines of first aid book. You just need to understand them. So, so now when vitamin E is deficient, you will see a hemolytic anemia and the shape of RBCs will be distorted like thorns, which we call acanthocytosis. And because the shape of RBCs are changed from its natural shape, when those RBCs will go to the spleen, okay, it will cross the spleen, they will break down. They cannot be passed and macrophages will eat it. So that is why we will see this hemolytic anemia where RBCs will be breaking down. Okay, and when the RBCs will be breaking down, the hemoglobin's level will be low, so you will see anemic patients. Got my point? Then you see demyelination of posterior columns and spinocerebellar tract. Okay, that will cause ataxia, that is the position of that patient, the gait of that patient will not be like symmetric. So he will be falling here or he will be falling there while moving. So that is called ataxia, means like no balance. Okay, and muscle weakness definitely, because uh, they are causing problems to one thing, they're causing problems to these posterior columns, okay, which also deal with your lower limb, but not the muscles. Okay, but here you're having this muscle weakness because of anemia. Okay, so blood carries oxygen. When your blood do not have sufficient RBCs, there is not sufficient oxygen. And when the sufficient oxygen will not be given to your muscles for the movement purposes, they will go fatigue. So the patient will complain of muscle weakness too. Okay, so clear your concepts. Then neurologic presentation may appear similar to vitamin B12 deficiency. Now this point is very important for your MCQ. This point. Okay, like very important, just mark it MCQ, make a box or something. Okay, so now see what is written here. The neurologic presentation may appear similar to B12 deficiency. I just told you that these things that are happening are same as B12. Okay, so you have to think B12 and E both. But what, being a doctor, what is the thing that will give you a signal that this is not B12 deficiency, but it is vitamin E deficiency? That signal will be looking at the CBC of the patient. You will see the morphology. They write a line in the last of your report that tells that the shape, the color of the RBCs. So when you will see that the RBC is not, it is not a megaloblastic anemia, you will see MCV for megaloblastic anemia. In I told you the normal value of MCV is 90 to 120. Okay, and in megaloblastic anemia, it is always more than 120. The MCV count is more than 120. When we will be studying hematology, I will explain you what is an MCV. Okay, so for now just write this value so to remember. So when the doctor, now the doctor comes with the differentials when he saw this, and he's like, okay, I made two differentials, vitamin B12 deficiency or vitamin E deficiency. But then he ordered the patient with a CBC. The patient comes back to his clinic with a CBC report, and he see that the MCV is not more than 120. It is in normal range. It is in normal range. Let's say it is 100. Okay, and then he see hemoglobin count drop, let's say 6, hemoglobin count drop, and then in morphology you find acanthocytosis. So now you will be sure that it is not vitamin B12 deficiency, because in B12 deficiency we have neurologic symptoms plus megaloblastic anemia. But in vitamin E deficiency, we have hemolytic anemia and acanthocytosis. We do not have megaloblastic anemia, but we have neurologic deficiencies. So you can write in your notes, okay, you can write it here that you can write it here that in vitamin B12 you will see megaloblastic anemia plus neurologic symptoms. But in vitamin E, you will see neurologic symptoms and no megaloblastic anemia, but you will see hemolytic anemia along with acanthocytosis. So now you see how MCQs are made. This is how they make MCQs. And then you have another vitamin which we studied was vitamin B9, folic acid. In vitamin B9, you were seeing hemolytic anemia, but you were not seeing neurologic symptoms. So it's the difference now, okay? So hemolytic anemia, but no neurologic symptoms. So yeah, now you see you have this picture. B12 with megaloblastic anemia and neurologic symptoms, E with no megaloblastic with hemolytic and neurologic, but B9 only hemolytic and no neurologic. So this is your differential diagnosis, and these are your MCQs. So remember these things, okay? Now I'm clearing this picture, okay? You can take a screenshot if you want to. Okay, so now hypersegmented neutrophils, okay, or increased serum methylmalonylic acid levels. So if you remember from our previous lecture, I have showed you this this diagram in vitamin B12, that this is methylmalonyl CoA, which is converted to succinyl CoA, and then it is responsible for the production of heme and TCA cycle. And I have explained you this picture in very much detail. So you have to go back and check this lecture, okay, for vitamin B12 if you want to understand. There are 3 MCQs that have been asked from this picture only, from these 2 pictures. So these pictures are very important. Go to my previous lecture and check on the MCQs, okay? So here also you will see these methylmalonic levels high, okay? So because why we will have a problem in these levels? Because of the fatty acid synthesis. So if I show you the Lippincott book, this is the Lippincott book, okay? So this is Lippincott, okay, your textbook. So if I show you in Lippincott what they have written in the functions, you see the primary function of vitamin E is an antioxidant, like most important, and in the prevention of a non-enzymic oxidation of cell components, for example, polyunsaturated fatty acids. So when it will hinder this process, you will see a problem in that pathway, and you will be having raise in serum methylmalonic acid levels, okay? So these things are important. Just keep in your mind for your MCQs. Okay, so in vitamin B9, you did not have these levels high. These levels were normal. But in vitamin B12 and in vitamin E, you have increased serum methylmalonic acid, okay, MMA, I'm writing in short. So in these two, you have these in rise. So like you can like make these little points somewhere and make boxes of it so that you may remember it when you'll be like revising for MCQs, and in these little review boxes will help you in your MCQs. Okay, now let's see excess of vitamin E. When we talk about excess, so up till now, how many vitamins we have talked about excess? The first vitamin was vitamin A, okay, then vitamin B3, we talked about niacin excess, okay, then we have talked about vitamin D, and now we have this vitamin E. So these four vitamins have excess given in your first aid, but among all of them, vitamin E is the least toxic vitamin that shows excess. So there can be excess in infants. In adults, it's not like too much, okay, and you will not see that, but this is the least toxic. The dose for vitamin E is normally 15 milligrams, okay? But even if you give 300 mg, it will not cause toxicity. It will not cause toxicity. Okay, so these are your points. So it in infants, when there is an excess in vitamin E, it causes enterocolitis. Enterocolitis means your gut lining, your small intestine, and your colon, your large intestine, they are inflamed. Okay, we see inflammation of small and large intestine, so that is called enterocolitis. Okay, now high dose, now this is important, very important point. High dose supplementation may alter metabolism of vitamin K, enhance coagulant effects of warfarin. So why we have not studied vitamin K, okay, it's remaining, but I'm telling you that vitamin K is responsible for the coagulation factors. We have 12 coagulation factors. Among those 12 coagulation factors, vitamin K is responsible for factor 2, 7, 9, and 10. Okay, these are the 4 factors for which vitamin K is responsible. So when there is no vitamin K, there is no these factors. When these factors will not be there, okay, your intrinsic and extrinsic coagulation pathways will be altered. Okay, so what vitamin E do? Vitamin E, if we give a higher dose of vitamin E to the patient, it will increase the activity of vitamin K. It will increase. Okay, so and when vitamin K activity will be increased, what vitamin K will do? It will enhance this anticoagulant effects of warfarin by making more and more these coagulation factors. Okay, so warfarin function is enhanced by this. So you have to like kind of understand that vitamin E increases the effect of warfarin. You can write it in your own words also, that vitamin E increases the effect of warfarin. Simple. Okay, warfarin is an anticoagulant. Okay, like it does not let your blood clot or coagulate. It is an anticoagulant drug. We give it to patients who have DVT, okay, who have thrombus in their blood. So we don't want that blood to clot or to coagulate. So that is why we give warfarin. We also give warfarin and all these things to to patients who are prone to stroke, okay, who are prone to pulmonary embolism. We give these drugs to those patients, but we do not give warfarin to patients who are undergoing any kind of surgery. So you also like, these are clinical points that I'm telling you, because the blood gets thinner, and when it will not clot or when it will not coagulate, there will be a tendency to bleed too much. Okay, so warfarin works opposite to these factors. Warfarin works opposite to these factors, and vitamin K make these factors. Okay, So what vitamin E is doing, it is increasing the activity of warfarin. That is, it is decreasing the activity of vitamin K. So you getting my point? So you can like write it down, like vitamin E is increasing warfarin activity. Okay, it is increasing warfarin activity. So when warfarin activity will be increased, vitamin K activity will decrease. Okay, so and what will be the result? No coagulation. Simple. Like, make it simple. So students, we are done with vitamin E from first aid. Now the next will be vitamin K, and I am stopping this lecture over here, and you have to join again from the WhatsApp group. Okay, join from the link again, and then we will take vitamin K along. Okay, because there is like less than 1 minute left, and this recording will automatically stop, so you have to join it again. Thank you so much. Please join again. I'm just ending this.